Welcome to the Noted Pharmacist, your trusted channel for pharmacy and medical education. Today, we continue our pharmacology lecture series with an in-depth exploration of parasympathomimetics, an essential drug class within autonomic pharmacology. Previously, we discussed the introduction to autonomic pharmacology, and if you missed that, you can find the link in the description. Additionally, a separate video featuring a quiz with 10 multiple-choice questions, answers, and detailed explanations is available to test your understanding of today's topic. Be sure to check the description for the quiz link. By the end of this video, you will understand the following. Number 1, the definition and therapeutic uses of parasympathomimetics. Number 2, recognize key drugs and their classifications in this drug class. Number 3, comprehend the mechanisms of action and physiological pathways of parasympathomimetics. Number 4, identify clinical indications and pharmacokinetics of these medications. Number 5, evaluate the adverse effects and safety considerations of parasympathomimetics. Number 6, understand management strategies for overdose, including key interventions and antidotes. We will also look at newer agents that have been developed under this drug class. Let's get started. Parasympathomimetics, also known as cholinomimetics, are drugs that mimic the effects of the parasympathetic nervous system, PNS. They achieve this by either directly stimulating muscarinic and/or nicotinic receptors or indirectly by increasing the availability of acetylcholine, ACH, at synaptic junctions. Clinically, these drugs are essential in managing conditions like glaucoma, myasthenia gravis, and postoperative ileus. Key drugs in the parasympathomimetics class include the following: bethanechol, pilocarpine, carbachol, cevimeline, neostigmine, pyridostigmine, idrophonium, and physostigmine. Each of these drugs serves a distinct therapeutic role, which we will explore throughout this video. Parasympathomimetics can be broadly classified into two categories. Direct-acting agents directly activate muscarinic or nicotinic receptors. Examples include pilocarpine, which acts as a muscarinic agonist, and carbachol, which acts on both receptor types. Indirect-acting agents inhibit acetylcholinesterase, ACHE, an enzyme responsible for degrading ACH. Examples include neostigmine and pyridostigmine. Here's a concise breakdown of the parasympathomimetics, categorized into direct-acting and indirect-acting agents. This table highlights how direct-acting drugs, like bethanechol and pilocarpine, target specific receptors, while indirect-acting agents, such as neostigmine and pyridostigmine, enhance acetylcholine levels by inhibiting its breakdown. Understanding these distinctions is crucial as we delve into their therapeutic roles and applications. Let's delve deeper into their mechanisms of action next. Direct-acting parasympathomimetics exert their effects by directly binding to and activating muscarinic or nicotinic receptors, replicating acetylcholine's physiological action. Bethanechol specifically targets muscarinic receptors in the bladder, inducing detrusor muscle contraction and improving bladder emptying in cases of non-obstructive urinary retention. This mechanism underscores their therapeutic relevance, particularly in conditions requiring enhanced parasympathetic tone to restore normal physiological function. Indirect-acting agents, such as neostigmine, inhibit acetylcholinesterase, resulting in prolonged ACH action at synapses. This mechanism is especially beneficial in conditions like myasthenia gravis, where enhanced neuromuscular transmission is required. Some of the parasympathomimetics drugs exhibit profound effects on the central nervous system, with indirect-acting agents like physostigmine playing a pivotal role. Physostigmine crosses the blood-brain barrier and is commonly employed to counteract anticholinergic toxicity by enhancing acetylcholine levels. This demonstrates the clinical versatility of parasympathomimetics, which extend beyond peripheral action to critical CNS applications. Now, let's discuss the clinical indications of parasympathomimetics. Parasympathomimetics, or cholinergic agonists, play a pivotal role in managing conditions linked to reduced cholinergic activity. One of their first approved uses is in glaucoma, where agents like pilocarpine reduce intraocular pressure by enhancing aqueous humor outflow. This property is particularly valuable in preserving optic nerve health and preventing vision loss. These drugs are also critical in treating myasthenia gravis, a neuromuscular disorder characterized by muscle weakness. Pyridostigmine is commonly used here, as it increases acetylcholine availability at neuromuscular junctions, improving muscle strength and endurance. This makes it indispensable for managing this autoimmune condition. Postoperative ileus and urinary retention represent another indication for parasympathomimetics. Bethanechol, a selective muscarinic agonist, stimulates smooth muscle contraction, aiding in the restoration of normal bowel and bladder function. This targeted action promotes recovery after surgical procedures. In Alzheimer's disease, parasympathomimetics like donepezil support cognitive function by boosting acetylcholine levels in the brain. This mechanism addresses the cholinergic deficit that contributes to memory impairment, underscoring its significance in neurodegenerative disorders. Off-label applications further showcase the versatility of parasympathomimetics. For example, cevimeline is effective in managing xerostomia in Sjogren's syndrome by stimulating salivary secretion. These uses expand the clinical utility of this drug class beyond traditional indications. Prophylactic uses include protecting against nerve agent toxicity in hazardous settings. Pyridostigmine is a reversible cholinesterase inhibitor used to block irreversible nerve agent effects, providing a safeguard in high-risk environments. This highlights the importance of parasympathomimetics in occupational and emergency medicine. Let's now explore the pharmacokinetics of these drugs. We are going to look at absorption, distribution, metabolism, and elimination. Parasympathomimetics exhibit variable absorption profiles based on their chemical nature and route of administration. Bethanechol, for instance, is poorly absorbed orally due to its quaternary ammonium structure but remains effective for conditions like urinary retention. Other drugs like pilocarpine, a tertiary amine, have better absorption due to their lipophilic properties, making them suitable for systemic and topical applications. The bioavailability of parasympathomimetics is highly dependent on their resistance to enzymatic degradation and first-pass metabolism. Drugs like neostigmine, a carbamate ester, demonstrate moderate bioavailability due to partial resistance to hydrolysis by cholinesterases. In contrast, tertiary amines such as pilocarpine show higher bioavailability because they bypass extensive first-pass metabolism. These differences make tertiary amines more suitable for oral administration, while quaternary amines often require parenteral routes to achieve therapeutic levels. The distribution of parasympathomimetics is influenced by their polarity and lipophilicity, determining their ability to cross membranes. Lipophilic drugs like physostigmine can penetrate the blood-brain barrier, enabling central nervous system (CNS) activity, which is crucial for treating conditions like anticholinergic toxicity. Conversely, hydrophilic agents such as neostigmine are largely restricted to peripheral tissues, limiting their CNS effects. These distribution patterns directly influence the therapeutic applications and side effect profiles of parasympathomimetics. Metabolism and elimination of parasympathomimetics are equally variable, often involving hepatic enzymes or esterases. Neostigmine, for example, is broken down by plasma esterases, whereas pilocarpine undergoes hepatic metabolism. Drugs like edrophonium, with a short half-life due to rapid renal clearance, are particularly useful for diagnostic purposes, such as in myasthenia gravis testing. By contrast, agents like pyridostigmine exhibit longer half-lives, making them suitable for chronic management of conditions like myasthenia gravis. Now that we've explored the pharmacokinetics of parasympathomimetics, let's shift our focus to their safety profile, a critical aspect of understanding these drugs. In this section, we'll delve into their adverse effects, serious risks, contraindications, and potential interactions, equipping you with essential knowledge for safe and effective use. Adverse effects of parasympathomimetics arise due to excessive cholinergic activity, reflecting their mechanism of action at muscarinic and nicotinic receptors. Clinically, this may manifest as bradycardia, excessive salivation, diarrhea, and bronchoconstriction, requiring vigilant patient monitoring. For instance, pilocarpine, a parasympathomimetic used in glaucoma, can induce bronchospasm and hypersalivation, especially in susceptible individuals, underscoring the importance of dose titration. Parasympathomimetics like physostigmine can induce CNS side effects due to their ability to cross the blood-brain barrier. By inhibiting acetylcholinesterase, they increase acetylcholine levels, potentially leading to overstimulation of central cholinergic pathways and adverse effects such as seizures, confusion, or tremors. This underscores the need for judicious use, particularly in patients predisposed to neurological disorders or those requiring careful dose adjustments. Severe adverse effects of parasympathomimetics, such as a cholinergic crisis, demand swift recognition and intervention due to life-threatening consequences like respiratory failure and profound bradycardia. This condition occurs from excessive stimulation of muscarinic and nicotinic receptors, often caused by drugs like pilocarpine when overdosed. Rapid administration of atropine, a muscarinic antagonist, serves as the cornerstone of treatment, countering the overwhelming cholinergic activity to stabilize the patient. Parasympathomimetics, while therapeutically valuable, require careful consideration of contraindications and cautions to ensure patient safety. These drugs are contraindicated in patients with conditions like asthma, where bronchoconstriction may worsen respiratory function, or peptic ulcers, as they can increase gastric acid secretion. For example, pilocarpine, used for glaucoma, can exacerbate urinary obstruction in cases of benign prostatic hyperplasia. Caution is warranted in individuals with epilepsy or Parkinson's disease due to parasympathomimetics' potential to lower the seizure threshold and aggravate motor symptoms, respectively. Understanding the pharmacological implications of renal impairment is crucial when using parasympathomimetics. Neostigmine, a cholinesterase inhibitor primarily eliminated via renal excretion, requires precise dose adjustments to prevent drug accumulation and potential toxicity, including severe cholinergic crises. Therefore, monitoring renal function and tailoring dosages are critical steps to ensure safe and effective therapy in patients with compromised renal clearance. While most parasympathomimetics are considered hepatologically safe, understanding their hepatotoxicity profile is crucial for ensuring patient safety during long-term therapy. For instance, bethanechol, a parasympathomimetic used in urinary retention, typically demonstrates minimal liver toxicity but still warrants monitoring in patients with pre-existing hepatic conditions or prolonged use to mitigate potential risks. Drug interactions of parasympathomimetics are critical to understand due to their potential to significantly alter therapeutic outcomes. These include antagonism by anticholinergics, which counteract parasympathomimetic effects, and additive toxicity when combined with cholinergic agonists or organophosphates. For example, combining pilocarpine, a muscarinic agonist, with beta blockers can lead to profound bradycardia, highlighting the need for vigilance when prescribing medications with overlapping or opposing actions. When using parasympathomimetics in pediatric patients, precision in dosing is paramount to balance therapeutic benefit against the risk of toxicity. For instance, neostigmine, a cholinesterase inhibitor, requires meticulous titration to treat conditions like myasthenia gravis, ensuring it enhances neuromuscular transmission without causing excessive cholinergic effects. Such careful management underscores the importance of weight-based calculations and close monitoring in this vulnerable population. Managing an overdose of parasympathomimetics requires immediate intervention to mitigate excessive cholinergic stimulation. Atropine, a muscarinic antagonist, serves as the primary antidote, effectively counteracting severe symptoms such as bradycardia, bronchoconstriction, and hypersecretion. Supportive care, including airway management and oxygen therapy, is vital in cases where respiratory compromise arises. Timely administration of atropine can be life-saving, particularly when dealing with agents like organophosphates, which potentiate acetylcholine accumulation. Recent advances in parasympathomimetic therapy have introduced agents like cevimeline, a selective muscarinic receptor agonist designed to target M3 receptors with greater precision. By focusing on M3 receptors, cevimeline effectively stimulates salivary gland function, making it a superior option for managing xerostomia, especially in conditions like Sjogren's syndrome. Its enhanced receptor selectivity also reduces off-target effects, improving the safety profile compared to earlier parasympathomimetics. To recap, we defined parasympathomimetics and their mechanisms of action. We discussed key drugs, classifications. We also discussed the clinical uses, pharmacokinetics, adverse effects, and safety considerations of this drug class. This comprehensive overview highlights their importance in pharmacology. Conclusion. In summary, parasympathomimetics play a critical role in managing a variety of conditions by modulating parasympathetic activity. Their diverse therapeutic applications highlight their importance in both clinical and pharmacological settings. Now that you understand parasympathomimetics, be sure to check out our next video on parasympatholytics, where we will cover their mechanisms, therapeutic uses, and key pharmacological differences from today's topic. Further reading. For a deeper dive, consider consulting resources such as Kazung and Trevor Clinical Pharmacology, Rang and Dale's Pharmacology, and BNF, British National Formulary. These references provide invaluable insights into pharmacological principles and clinical applications. If you found this video helpful, please give it a thumbs up and subscribe to The Noted Pharmacist for more high-quality pharmacology content. Share your thoughts or questions in the comments section below, we'd love to hear from you. Remember, learning is a continuous journey. Thank you for watching, and we look forward to seeing you in the next video.